Hello everybody, this week we're going to be looking at sepsis and going beyond buffalo. We're going to go a little bit more in depth than usual, looking at risk factors, pathophysiology and the management of sepsis. So that means cultures, ideally 2 sets of blood cultures. The reason behind this is simply the pickup rate. The more blood you take, the higher the chance we can isolate the organism. 1 full pair gives about an 80% chance of isolating the bug versus over 90% with 2 pairs. However, if we think about it, how often do we ever get a full pair? Often we only partially fill the bottles, and the chance of isolating an organism is well below 80%. So the more you can get, the better. Antibiotics within an hour. That means prescribing within 30 minutes of the patient triggering red flag sepsis. This gives the nurses a chance to draw the antibiotics up and get them started within the hour. So to hit the 30 minutes to prescription, we need to be proactively reviewing the CAT2s quickly and keep an eye on the OBS on FirstNet, as any red OBS are red flags and we need to be making quick assessments for suspected infection. Don't delay for tests. If you suspect infection, your clinical judgment of source is often right, and delaying for tests is just an unnecessary delay. Fluids. 500 ml crystalloid. A single 500 ml is not likely to send the patient into a crushing LVF. However, 500 ml is not the end of it. We need to assess the response and potentially keep going with those fluids, maybe up to 30 ml per kilo, about 2 litres for a 70 kilo adult in septic shock, and potentially onto vasopressors. Unfortunately, what we see all too often is 1 bolus being given in ED, but despite the patient being hypotensive, it's often left to the inpatient teams to manage, leading to the predictable poor outcomes. Lactate. This is important for both diagnosis and monitoring. As you're aware, if the VBG has been difficult or done poorly, you can get an artificially high lactate, but please don't assume it's that. If you're going to discount it, please recheck it. And remember to document the lactate in your notes, as it's not pulled through to the result system yet. Oxygen, we're just looking for normal oxygenation levels for that patient, but please remember to prescribe it. And finally, urine output. It's not something we often have time to meaningfully measure in the ED. However, it is a really important indicator of end organ function and a guide to treatment, so we can make a start within the ED by measuring any urine output. But now back to what we promised, a slightly more in-depth look into sepsis. Some of you will have heard about the definitions changing in Sepsis 3.0 with the International Consensus Group. They simplified the definitions and tried to remove some of the dead wood. Infection. So that's just as it says, infection. It's a normal response to an infection. Sepsis. We'll look at the full definition in a second, but essentially it's an infection that has a dysregulated response causing end organ failure. And septic shock, which is sepsis with persistent evidence of shock despite resuscitation. So sepsis, as we said before, is not just a bad infection. It's precipitated by an unregulated and disproportionate response to infection and leads to life-threatening organ dysfunction. So septic shock goes beyond this, leading to a profound circulatory and metabolic abnormality. And this is defined as requiring vasopressors to maintain a MAP of 65 despite fluid resuscitation. So firstly, MAP, that's mean arterial pressure. And you'll see that in brackets under the blood pressure on the resus monitors. You can calculate it, but essentially it equates to a systolic below 90. Adequate fluid resuscitation, we're generally looking for about 30 ml per kilo of crystalloid, as we'd said earlier. But we don't give that all at once, we're doing it in boluses and looking for response. And as you might expect, the mortality is very high, over 40% in septic shock. Now, some of you will remember the concept of SIRS, aka Systemic Inflammatory Response Syndrome, and wonder if it's playing a part in sepsis at all anymore. Well, the consensus group stated SIRS was neither sensitive or specific, which fits with the experience of those of us that used SIRS, as everyone seemed to trigger in ED. And the consensus group go on to say that the triggers we look at in SIRS were just the body's reaction to danger, so not specific to sepsis, but just a general reaction to something bad going on. And studies in Australia showed that SIRS actually missed 1 in 8 septic patients that ended up on ICU, so it's not even sensitive. And hence, it was dropped from Sepsis 3.0. But the eagle-eyed among you might have noticed it's not completely gone from nice. In the amber flags, which if you remember you need 2 of, plus either a new AKI or an elevated lactate to generate a red flag diagnosis. SIRS is hidden within it. Respiratory rate 21 to 24, heart rate above 90, systolic blood pressure below 100, and a temperature of less than 36, all creeping into the amber flags. Now we've gone through the definitions. Who is at high risk of sepsis? Well, the first group won't be a surprise to anyone. It's the elderly. It often feels like every other elderly patient in ED has sepsis, which is a bit of an exaggeration. However, there is some truth in it. While the elderly make up only 12% of our population, they account for 65% of our sepsis cases, which, when we think of the definition of sepsis as showing organ dysfunction and dysregulation, this shouldn't really be a big surprise to us. And as you would expect, mortality and morbidity rates are high, so early recognition and treatment is essential. Next is us men. Just like man flu, we are far more likely to get sepsis than women. The reason for this is not known, however theories around sex hormones and women being better able to modulate their response may underlie this difference, or men just moan more about it. Being groups are roughly twice as likely to develop sepsis compared to the white population, with Afro-Caribbeans doing even worse. Again, this is not understood, and genetic, cultural, socio-economic, and access issues have all been raised as potential issues. However, it's likely to be a mixture of these. Immunosuppressed patients, so those on chemotherapy, anti-rejection agents, long-term steroids, and diseases such as HIV, all have an impaired response to fighting infection and an increased chance of sepsis. Genetics, this has a massive influence on susceptibility. A large study in Denmark looked at what happened to the children of those who died of sepsis. It showed that the natural children of those who died were about 6 times more likely than average to also die of sepsis. However, if you were an adopted child, your risk of death from sepsis was no more than the general population. The genetic factors are not fully understood, and it's likely to be a combination of genes. As usual, alcohol, smoking, and low vitamin D all predict increased likelihood of developing sepsis. One thing that struck me going through this was how similar it was to the COVID risk factors, which made me wonder why we found those so surprising when this data has been around for years. So now we've gone over who's likely to get sepsis, we should probably look at why we get sepsis. As you might expect, the pathophysiology of sepsis is quite involved, but you can distill it down to one simple thing. It's all about the linings. Now this diagram shows how the linings are affected with an infection. Even though this is a beautifully simple diagram explaining how sepsis works, even after staring at it for ages, I couldn't get my simple ED brain around it. Until I realised the police had just been copying our immune response to deal with riots and mass disturbances. So what do they need to do? Well, they need activation. They need to recruit a large force. They use some nets. They try and subdue the offenders. And finally, they search and destroy. So firstly, activation. The police rely on 999. We, however, have several systems. Initially, we have PAMPs, or pathogen-associated molecular patterns, which is basically your cells directly recognising the pathogens, or seeing that riot coming down the street. But if you miss the riot walking down the street towards you, you might recognise the devastation left in its wake, or DAMPs, damage-associated molecular response, which is basically finding the broken cells. We unfortunately don't have millions of tiny phones to call 999, so we rely on cytokines, which include interleukins, TNF-alpha, and many others. Once the call's gone out, there's no point just sending one sleepy cop at the end of his shift to the riot. You need to recruit, retain, and activate them. And we do the same with our immune cells. We release more, we lengthen their working life, and we activate them so that they're ready to fight the infection. And when they get to the scene, they go to work. And what's the easiest thing to do? Catch the bad guys in a net. And essentially, your immune cells do the same. They release their nets, also known as neutrophils' extracellular traps. They're basically a protein scaffold, or net, containing antimicrobial enzymes and proteins to immobilize and kill the bugs. And they're procoagulant, to help a clot form around the net and encase the pathogen, trapping it until it can be dealt with later. However, you can't catch them all with a net or a gun, so you subdue them to make it easier to catch them. As you can see here, the police do exactly the same with tear gas, but our immune cells, they use reactive oxygen species. The reactive oxygen damages lipids and proteins, which in turn disrupts the cellular membranes and the mechanics of the cell. It also damages the DNA and RNA to prevent replication and protein formation, and then knackers the mitochondria to disrupt the energy supply. Just like tear gas, reactive oxygen species are a blunt weapon that affect everything in the area. But like the police wearing gas masks, your cells are more able to cope with the oxidative stress than the pathogens. Once subdued, it's easy to get the ones within the blood, but if they're within your tissues, you need to get at them. The police use battering rams to get at the crooks, but we don't have that level of technology. So we increase the endothelial permeability. This allows the immune cells and proteins to enter our tissues and destroy the pathogens. So how could this go wrong? In most cases, nothing goes wrong. The infection is localized, and any collateral damage is easily fixed. But sometimes things go too far. The standard policing doesn't work. The trouble spreads, and just like Bush's poll ratings, things start to slide. There's overactivation. Pathogens are detected all over the place, triggering the PAMPs system. And the damage caused both by infection and the collateral damage of the immune reaction trigger the DAMPs system, increasing release of cytokines throughout the body. And this has consequences. Animal studies have shown that simply by giving TNF-alpha, it leads to the animals developing sepsis-like syndrome and dying. However, in the same study, it also showed that giving a TNF-alpha blocker could prevent an infected animal from developing sepsis and reduce mortality. However, before you think that this will make a great treatment, they found that they had to give their blocker 2 hours prior to infecting the animal, which is not particularly practical within the human population. So all that cytokine release throughout your body does its job, but they over-recruit. We run out of mature immune cells to release, so we start releasing less effective immature cells. And the fact that we're activating all of these immune cells means that we move away from a targeted policing to the police running amok and attacking both pathogens and innocent cells. And they start firing their nets everywhere. Unlike the targeted response to a simple infection, they're firing their nets indiscriminately. And as we said, each of these nets is a procoagulant forming a microembolus. These microemboli go on to clog up the capillaries. And remember, the capillaries is where the exchanges of gases, waste and nutrients all happens, which in turn hampers organ function. And all this microemboli formation uses up your clotting factors, which left unchecked will precipitate bleeding and DIC, or as the intensivists refer to it, death is coming. And remember, it's not just the nets. Tear gas is getting thrown everywhere. The reactive oxygen species concentration is increasing and in time overwhelms the cell's gas mask or protective functions. This disrupts the DNA, which hampers the mechanics of the cell. The membranes are also disrupted, reducing function and potentially splitting the cell or lysing it. The reactive oxygen also causes mitochondrial dysfunction. Initially, cells develop an energy deficit, but as this increases, the cells start to go into hibernation. Remember, organ function is not a passive thing, and all these hibernating cells disrupt organ function. For example, in the kidney, when the cells hibernate, the iron pumps stop working, and concentration gradients are lost, so kidney function falls. But if the concentration of reactive oxygen continues to increase, the cells run out of energy completely and die. But also, all this activation means that the immune cells are knocking down doors everywhere. Endothelial disruption becomes widespread, causing edema within all the tissues, which doesn't only compress the structures of the organ, but also reduces the exchange of vital gases, nutrients and waste products, and causes increased organ dysfunction. So how does this affect the individual organ systems? Well, the cardiovascular system is often the system we concentrate on most. As function is disrupted, you start to lose vascular tone, so your blood vessels expand. Your cardiac output does increase in response to this, but as things deteriorate, the effect reduces. And as things worsen, it gives way to the symptoms of septic shock. We can try and maintain your blood pressure with fluid, but when your vascular system has little tone, the vascular space increases from around 5 litres to more than double that, and hence simple fluid replacement can't fix it alone. We need an artificial squeeze of noradrenaline. Lung function is something that also worries us. As we described earlier, all those holes that develop with increased endothelial permeability mean edema develops, and with this, gas exchange is inevitably reduced. But not only that, all those microthrombi forming from the nets have to end up somewhere, and large capillary beds, such as the lungs, will trap them happily, reducing the flow through the capillaries and around the alveoli, which also hampers gas exchange. And with the edema and the microthrombi, ARDS will develop. Our knowledge of how the kidney is affected during sepsis has changed recently, moving away from the idea that AKI was merely down to the poor perfusion secondary to shock, and more towards internal organ dysfunction. The microvascular occlusions and damage reduce the blood flow through the nephron, hampering the ability to excrete waste and maintain gradients. Membrane damage and edema also affect the nephron function, and the cell damage and hibernation just stop the nephron from working, all this leading to the development of an AKI. In the nervous system, we have 2 main issues. Firstly, as endothelial damage progresses, edema and poor exchange hampers brain function. But like the kidney, oxidative stresses also induce hibernation, and what we see is the development of delirium, and as things progress, coma. We also get vagal stimulation due to cytokine release, and studies have demonstrated that vagal stimulation alone can lead to endothelial damage, independent of sepsis. Hormonal issues. As you can imagine, with all this microvascular damage and endothelial disruption and hibernation, hormone production is reduced. However, as part of our response to danger, we get an adrenaline release. This can cause glycolysis, which is thought not only to drive blood glucose levels up in sepsis, but is also thought to be the driver behind the elevated lactate levels we see in sepsis, rather than hyperperfusion alone. So if we look back at those red flags, we can see why they develop. Within the lungs, gas exchange is hampered, driving up the respiratory rate. And when this compensation starts to fail, our SATs also drop. Our cardiovascular system struggles to cope with the vascular dilation, increasing your heart rate and reducing blood flow to your skin, i.e. the mottling. And when this fails to keep up, your blood pressure drops. Your brain function declines, making you more and more drowsy. Renal function declines, initially developing an AKI, but then anuria. As we develop microemboli and use up our coagulation factors, we see purpura and DIC. So how do we treat it? It's buffalo, and then ICU if it fails. If we take a look at this table of evidence behind what we do, and I don't expect you to read it all right now, but just look at those dots. Red meaning harm, amber is no effect, and green shows something actually improved outcome. The only treatment shown to be of benefit was the early goal-directed therapy developed by Rivers et al. In 2001, which introduced early antibiotics, fluid bolus and vasopressors to maintain your blood pressure, oxygen targets, but also other things like keeping your hemoglobin up. And this really changed how we looked at and treated sepsis across the world. Before that, it was like trauma prior to ATLS. Even clear cases of sepsis rarely got antibiotics within 8 hours of admission, and we gave very little fluids. However, Rivers et al. Changed everything. But then fast forward to 2014, and we have the Process, Arise and Promise trials, all big multi-centre RTCs based in the US, Australia, New Zealand and the UK, all looking at whether early goal-directed therapy was beneficial at all in septic shock, and all of them showed early goal-directed therapy provided no benefit over the usual treatment. So why did we see a benefit in 2001 but not in 2014? Well, that wasn't because the early goal-directed therapy proposed by Rivers was wrong. It's more because the landscape has changed. All three of these RCTs had their basic care arm of early antibiotics, large amounts of fluids. In the UK and Australia, patients were getting 2 to 3 litres of fluid, and in the US were getting significantly more than that. And they were then getting vasopressors if the fluids didn't work. They also all received oxygen therapy. What this change probably does indicate, though, is the complex stuff that was in the Rivers protocol probably has very little benefit. But the things we can do in ED, such as early antibiotics and fluid therapy, are really the big wins. Now, if we look at the red ones, one of them is important to the way we work in the UK, and that is that colloids cause harm. And it makes perfect sense if you think about it and the pathophysiology. Colloids are thought to keep the fluid in your vascular space because they have big molecules in them that keep the fluid in there through osmotic pressure. However, in sepsis, those big molecules can happily go through all those holes punched in the endothelium and drag the fluid with them, worsening the edema that's already happening. But all of these are really supportive measures. With all the processes we've so far described, you would think there's some therapies that would work. But as you can see from this table, there's only 2 therapies that have been shown to have any benefit. The green trial near the top is TNF-alpha blockers that we talked about earlier, which work well, but only if you deliver them 2 hours before you actually get the infection, which is tricky. However, the human trials did show a very modest benefit. However, this benefit is so small, they have not been approved. The second positive trial, about halfway down, is for activated protein C, which has been approved. However, even that is controversial, as one of the side effects is the major hemorrhage, and we haven't really established which subgroup is likely to benefit from this therapy. So what's the current state of play? Well, first thing to do, try and reduce the activation. Giving those antibiotics early will hopefully limit the bacteria and reduce the PAMPs process, but ensure we try and get cultures first so that we can target the antibiotics most effectively. Ensure the patient's oxygenated to help prevent damps, but remember, reactive oxygen species cause damps, so we don't want to go overboard with the O2. Fluid needs to be delivered in boluses, but remember to look for a response. Normally start with 500 ml, which is unlikely to cause any harm. We can progress up to 30 ml per kilo in boluses, so we can get that MAP up to 65 or the systolic up to 90. And if we can't get it that high, then we need to think of inotropes. With all that fluid, it's important to monitor its effect. The urine output is really useful for that. However, if this fails, we need to start supporting the patients while they try to recover, as we don't really have anything else that we can do. So for the respiratory system, that's thinking about ventilation for ARDS. Vasopressors, if that fluid isn't working well enough. Glucose control, evidence suggests aiming for around 8 to 10 millimoles per litre, but really avoiding hypoglycemia is just as important, and using the COVID hypoglycemia protocol can be very useful. However, all these things are very intensive, and despite them, mortality and morbidity is high. So we need to think about what's best for our patients and what they think is truly beneficial, especially as the majority of sepsis patients are elderly. Intubation is typically needed if ARDS develops. We need to think about what's the patient's respiratory reserve, what are their chances of being extubated successfully, and the risks of ventilator-induced infections. Then there's vasopressors, which involve central access and monitoring. All too often need high doses, leading to the death of the bits of you that have poor circulation. As you can see here, fingers and toes can often go missing, and dialysis also requires you to be in ICU with a large line in your neck. Plus, none of these are guaranteed to work, and all of them have major drawbacks, so we need to consider how far we go very carefully, not only for resource management, but also for the best outcomes for patients. And this can be difficult, but in most cases we have time to do this. The initial phases we're delivering are simple treatments, fluids, oxygen, antibiotics, but this gives us time to talk to ICU, seniors, patients and relatives to find out what really would be the best for this patient if they do go on to deteriorate. And we need to be open with them and our thought processes and what the likely outcomes are so they and us can make the best decisions. Once that decision's made, remember to document it, and all those discussions you've had, they're really important. And finally, we need to recognise sepsis early. Think about those red flags and be proactive so that we can start that treatment early and prevent progress, because that's our biggest win. Resuscitate and support that patient, and don't give up after 500 mils if that blood pressure isn't above 90. Then review, how is the treatment helping and what escalation is appropriate for this patient. So thanks very much for listening. I hope that was helpful, and I'll see you soon.